You can start your presentation.
Good evening, one and all. Today I'll be talking about a case of bilateral peritonsillar abscess. Let's start with the patient particulars. Mr. SK, who is a 58 years old male and a retired government employee from upper middle class and a resident of Guwahati. He presented with the chief complaints of pain during swallowing since 3 days, change in voice since 3 days, and swelling in left upper neck near the lower jaw since 3 days. The patient was apparently asymptomatic 3 days ago when he suddenly developed pain during swallowing. This pain during swallowing was sudden in onset, rapidly progressive, more with solid food than liquids, associated with pain while opening mouth, associated with foreign body sensation in throat, associated with foul smelling breath. Then the change in voice, which was sudden in onset, rapidly progressive, associated with pain while speaking. Then the swelling in left upper neck near the lower jaw, which is acute in onset, rapidly progressive, associated with pain. There is no history of fever, earache, weight loss, drooling, ulceration, cough, night sweats, difficulty in breathing, foreign bodies ingestion, and stiffness of neck. Past history. There is no history of similar complaints in the past. The patient is a known case of diabetes mellitus and hypertension since 5 years, and he is on irregular treatment. There's no history of tuberculosis, asthma, coronary artery disease, stroke, epilepsy, chronic kidney disease. And there is no history of undergoing any surgery in the past. There is no history of any allergy to drugs or food as such, according to the patient. Personal history. The patient consumes a non-vegetarian diet. His appetite is normal. He has an adequate sleep. Regular bowel and bladder movements are present. There is a history of betel nut chewing and no history of tobacco chewing or smoking, no history of alcohol consumption. There is no history of similar complaints in the family and no history of any chronic illness in the family. General examination. Consent of the patient was taken prior to physical examination. Patient is conscious, coherent, and well oriented to time, place, and person. Patient is well built and nourished. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. His vitals were at the time of examination: pulse 86 beats per minute, blood pressure 140 by 90 millimeters of mercury, respiratory rate 22 breaths per minute, temperature 97.2 degree Fahrenheit, saturation SpO2 by pulse oximetry 97% on room air, and random blood sugar was 420 milligram per deciliter. On systemic examination, it showed no abnormality. Coming to ENT examination, the oral cavity and oropharynx. Mouth opening was restricted and painful. Patient had poor orodental hygiene. Lips, teeth, gingivo-buccal sulcus, gingivo-labial sulcus, the tongue, hard palate, and retromolar trigone, they were normal. Uvula was swollen and congested with mild deviation to right side. Bilateral anterior tonsillar pillars appeared congested. The left tonsillar enlargement was seen, which was grade 3, and right tonsillar enlargement was also seen, which was grade 2. The soft palate, it showed a non-fluctuant, non-pulsatile, tender swelling palpable on the left side. And posterior pharyngeal wall appeared congested and there was no bulge noted. Neck on inspection, approximately 2 cm into 2 cm diffuse swelling was noted in the left submandibular region of the neck, closer to the angle of the mandible. No scars, discharge, ulcers, erythema of skin, engorgement of veins were noted. There is no restriction in the neck movements. On palpation, there was local rise of temperature. Findings on inspection, they were confirmed, sir. And swelling, it measured 2 cm into 2 cm. It was diffused, tender, firm, non-fluctuant, and immobile. No other swellings were palpable in the neck. Trachea is in midline. Carotid pulsation was felt bilaterally, and laryngeal crepitus was also felt. On auscultation, no bruit was heard. Examination of nose, it showed no abnormality, sir, on examination. Ears, on examination of both the ears, sir, no abnormality was detected, sir. Even the tuning fork tests were normal. My provisional diagnosis at the time of examination was left-sided peritonsillar abscess. Left-sided being because the patient mainly had pain in the left side of the neck also. And though both tonsils were enlarged, the pain was typically in left side of the neck. So my first diagnosis was left-sided peritonsillar abscess. Differential diagnosis, it could have been peritonsillitis also, mainly towards the right side, and infectious mononucleosis, parapharyngeal abscess, parapharyngeal tumor, extracranial internal carotid artery aneurysm, and malignancy. Upon investigations, his total leukocyte count was 11,700 cells per cubic mm. Highly sensitive C-reactive protein was more than 200 milligram per liter. The procalcitonin level was 0.5 nanogram per ml. His HbA1c was 15%. Then contrast enhanced MRI was done for this patient, which showed a T2 hyperintense collection in the left peritonsillar space, measuring about 18 millimeters into 13 millimeters, with surrounding inflammatory changes, peripheral rim enhancement, and another small hyperintense collection with peripheral rim enhancement in right peritonsillar space, measuring 12 mm into 13 mm. So this was, according to the scan, it was suggestive of bilateral peritonsillar abscess along with few bilateral subcentimetric level 2 lymph nodes. A throat swab was also done at the time of examination, uh, which eventually the report showed the growth of Klebsiella species. His viral markers were non-reactive. This is the scan which was contrast enhanced MRI done. This is the abscess in the left peritonsillar space. This was about 18 mm in size, and this is the right on the right side, which is a smaller one. It's about 12 into 13 mm. Coming to the anatomical aspects of it, the peritonsillar space, it lies lateral to the capsule of the tonsil, sir, and medial to the superior constrictor muscle. So in the peritonsillar space, we can see the paratonsillar vein and a loose areolar tissue. So lateral to the peritonsillar space, the first boundary is the pharyngobasilar fascia. Lateral to that lies the superior constrictor. Lateral to that is the buccopharyngeal fascia, and eventually the lateral pharyngeal space or parapharyngeal space. So the management aspect of this, the patient was in a propped up position and he was started on IV fluids and liquids orally. So we started him on injection metronidazole 500 milligrams IV thrice daily, injection cefuroxime 1.5 grams IV twice daily, and we took a consultation of our medicine colleagues. They started him on injection degludec, which is a long-acting insulin, based on the 2-hourly sugar monitoring. It was administered, and injection meropenem 1 gram IV with 100 ml NS thrice daily. This was after obtaining the first culture sensitivity report. He was sensitive to meropenem, so we started him on this. Then gargling was advised for the patient after every meal with povidone iodine 2% weight by volume solution. And we actually took a bit longer time here. Between this conservative management and the drainage, incision and drainage of left peritonsillar abscess, there was a gap of 5 days. The reason being, when we first told him about his condition, explained to him the need for the incision and drainage, the patient initially did not give his consent. But he did not improve 5 days later. After 5 days also, he did not improve. So we took his consent, explained him again. He agreed, and we took him to the minor OT and did incision and drainage. And the pus that we obtained, sir, it was sent for culture and sensitivity. So 48 hours later, based on the report, he was sensitive for both meropenem and ciprofloxacin, and it showed the growth of Klebsiella species. So we started him on. We added this injection ciprofloxacin 0.2% also, 100 ml IV twice daily. Now on the same day in the evening, he started. We did not drain on the right side initially, because the moment we drained on the left side, he had immediate relief. So we thought, since the abscess on the right side is small, we'll conservatively manage and see. But 2 days later, in the evening time, he developed pain on the right side of the throat. So next day, we took him to the minor OT again. We did incision and drainage of the right peritonsillar abscess, and he was relieved immediately. Compared to the left side, the pus that we collected, it was less, but whatever was obtained, we sent it for culture sensitivity. That also showed growth of Klebsiella species. and same, it was sensitive for ciprofloxacin and meropenem, and the drugs were continued. Patient improved symptomatically within the next 48 hours of incision and drainage of right peritonsillar abscess. In those 48 hours, he did not have any recurrence of pain or difficulty in swallowing or anything as such. His voice also improved. So actually, 1 day later, after the right incision and drainage, we did fiber optic laryngoscopy. It did not show any gross abnormality. And eventually, a day later, he was discharged in a clinically stable condition, and he was advised to come for further follow-up after 2 weeks. This is the picture of right peritonsillar abscess. And as we can see here, even I had mentioned that we had seen grade 2 tonsillar enlargement, but this is a day after he developed the pain on the right side. The size actually increased. So we did the incision and drainage, and within 48 hours, he was all right. Now, possible complications of a peritonsillar abscess will include parapharyngeal abscess, a retropharyngeal abscess, aspiration pneumonitis, sepsis, and Lemierre syndrome. Thank you.
Okay, good. So can you just skip to the history once more? We'll just keep on revising slides after slide and come to
Yes, sir.
comment upon your work on whatever case you have taken. Dr. Datta, you are free to ask anything in between, whatever you please.
Yes, sir. Thank you, sir. Thank you, sir.
I mean, you are as good as me, so I don't mind if you have any point. I mean, you
No,
can
sir.
just point out.
No, sir, it is not like that.
Oh, no, yeah, I know
Yes.
that.
Yes.
Anyway, so these are your chief complaints. So
Yes, sir.
your history is just for 3 days.
Yes, sir.
3 days before the patient was absolutely fine, or he had something else?
No, sir. I asked him again. He said prior to 3 days, there were no complaints.
Okay, fine. So what was the onset like? Was it sudden? Was it acute, insidious, chronic, or what?
Sir, this seems like sudden in onset only, sir. He has given history of less than less than 1 week, and within 1 week, we can consider everything the symptom as acute only, sir.
So that's acute onset, not sudden.
Okay,
Right.
okay, sir.
So, I mean, he started first with pain in swallowing.
Yes, sir.
He didn't have any pain on rest. He didn't have any pain in throat. He just had simple pain in swallowing. And then gradually, did he have pain in throat even on rest or only on swallow?
Patient, sir, first initially started with parents during swallowing, sir. But later on, when he presented to the hospital, then he had mentioned that he had pain while rest also. But during those 3 days, he did not have it.
Okay. So the change in voice, what sort of voice was the patient having?
Sir, it was more like muffled, sir, as if it's like hot potato voice.
Yeah, hot potato voice. That's the literal term used with it. Good. So you said that there was a swelling in the left upper neck near the lower jaw since 3 days. That was
Yes.
also since 3 days.
Yes, sir.
But your examination finding says that that swelling is probably a lymph node in the submandibular gland.
Yes, sir. Swelling was more in the posterior portion of the submandibular area, sir, when we palpated.
So would you like to label it as 1B or 2? I mean, the area of the lymph node, level 1B or level 2?
Sir, technically it could be 1B, sir. But when we did the scan, there was nothing in 1B. It was actually showing subcentimetric nodes in level 2.
Okay. So, I mean, did you do a ultrasound for that thing?
No, sir. We
So,
didn't.
fine. So, just CT showed sub-centimeter lymph nodes in level 2. But,
Yes, sir.
I mean, this significant swelling was in submandibular area.
Yes, sir. In the posterior parts.
So, what is the drainage of the peritonsillar space in terms of a lymph node?
Sir, there are lymphatics going into parapharyngeal space, and eventually these lymphatics they drain into the upper jugular group of lymph nodes, sir.
Correct. So, do you think that, I mean, whatever peritonsillar abscess he had,
Sir.
was it preceded by some attack of acute tonsillitis also? Or it was just like abscess starting in the peritonsillar space as such without affecting the tonsil? What do you think like that?
Sir, there has to be a tonsillitis first, sir, because the upper pole of tonsil has crypta magna, which is the largest crypt. Possibly a food particle or something must have been trapped there. Infection might have developed. It would have given rise to intratonsillar abscess that must have burst, causing peritonsillitis. From
Correct.
that on, there will be formation of phlegmon, and eventually a wall is formed leading to an abscess formation.
Okay, fine. Say, for example, if you have a unilateral tonsil enlargement,
Sir,
what can be your differential diagnosis?
Sir, it can be peritonsillar abscess, unilateral. It can be peritonsillitis also.
Okay.
Then there can be parapharyngeal abscess for a diabetic patient like this.
Okay.
And if there can also be potential retropharyngeal abscess also, but but for that the posterior pharyngeal wall will show a paramedian bulge. So in this patient it is not there. So but still that can be considered as differential diagnosis. Then for his age, he has habit of betel nut chewing also, and there can be malignancy in that area.
Malignancy in that area. For you're trying to say about the unilateral tonsil enlargement.
Yes, but
Oh,
the duration would be longer.
okay. What are the other differential diagnoses for a simple unilateral tonsil enlargement?
Uh, then comes the sir. There can be this thing parapharyngeal space tumors also,
Yeah.
like
Right.
deep lobe of parotid can expand, causing bulge in soft palate, and the tonsil can be pushed medially.
Right. The parapharyngeal tumors and the parapharyngeal abscesses and the peritonsil abscess, they have a tendency of pushing the tonsil, right?
Yes.
Talking about tonsillar enlargement. If you have a tonsillar enlargement, what can be your differential? You told about malignancy. One.
Hmm.
Similarly, if you have an enlarged tonsil, what differential diagnosis would you like to make in that case?
Uh, Enlarged tonsil, first is the infective causes. First thing is that.
Oh,
And infectious mononucleosis also can be there.
yeah.
But that is compared to this patient, that is seen in bilateral tonsil. We see bilateral enlargement. And the age groups are there, it is seen in pediatric age group and younger adults.
Okay. I just wanted to listen from you the basic local tonsil pathologies like tonsillar cyst, something
Okay.
that's I mean, which caused the enlargement of tonsil. I'm not talking about abscess per se, I'm just talking about the unilateral enlargement of tonsil.
Okay.
So, what sort of malignancies would you think if you have a unilateral enlargement of tonsil?
Sir, first thing that would come to my mind is squamous cell carcinoma.
Oh, yeah. Next.
Then there can be adenocarcinoma because it's all glandular structure there.
Okay. Then,
Then we can have this thing. Uh, um, we can have this thing in the deep lobe of parotid with malignancy. That can
just
also,
one.
if it expands.
Okay. Then again.
Then there's one more thing. Uh,
You need to remember lymphoma also.
Lymphoma.
Lymphoma,
Yes.
external lymphoma, they present in tonsil, right?
Okay. Okay.
So, I mean, coming back to the change in voice, do you expect the change in voice to be more in bilateral quinsy or unilateral peritonsil abscess?
Sir, I think bilateral, sir, because literally his throat is literally stuffed, and
Correct.
he will have difficulty in speaking also. His articulation may not be proper for us to hear it.
Okay, fine. Uh, your chief complaints, they do not include fever. Although you have straight away showed that he has a very high total leukocyte count, and you are counting more as an infectious cause.
Yes,
So
sir.
there was significantly no fever.
No, sir. At the time of examination, when he came to the hospital, his temperature was 97.2 degree Fahrenheit when we had checked the temperature. I
Did
asked him for the
patient-
history of fever. He said he denied it, sir. He did not say that he had fever at all.
So when do you call a patient having fever? How do you define fever? Say, for example, let's say some patient has a fever. So when you call it as a fever, just taking temperature on one single occasion, is that fever?
No, sir.
Patient might have had some sort of antipyretics also. So when do you call it as a fever? I mean, the classical Harrison definition of fever, when do you call it as fever?
Sir, above 100 degree Fahrenheit for
When it persists on a single occasion, or I mean, you have it, I mean, say, for example, you do some sort of an exercise, then your temperature rises a bit. You are absolutely right. It should be more than 100 as per the latest convention.
yes.
I totally agree with you. But point is, uh, I mean, did you ask the patient whether he had some sort of antipyretics before you measured fever or something of that sort? You measured
Yes, sir.
fever only on a
I
single occasion?
I asked him, sir, whether he had taken any paracetamol tablets or anything. He said no.
So, did you measure fever only on a single occasion or on multiple occasions?
Sir, I measured it twice, sir. The
Twice.
first time was this thing on day one when he came, 97.2 degree Fahrenheit.
Okay.
That day again I did not measure, but the next day again we checked for temperature. It was 98 only, sir.
Okay, fine. So there was a swelling. You can skip to the next slide.
Sir.
Fine. So you said pain during swallowing is a sudden in onset. I have a strong reservations about this word sudden, because sudden you see like in cerebrovascular accidents. That is sudden. It
Okay, sir.
happens within seconds. But here you have a duration of 3 days.
Sir.
You can really call it rapidly progressive, no doubt about that, but it's not really sudden. It's an
Okay.
acute onset,
Acute and okay,
right?
sir.
Uh, you say that he was asymptomatic 3 days ago. So whatever happened, that happened just within 3 days.
Yes.
Okay, fine. So the more for solid foods than liquid. What do you mean by that? Pain during swallowing is more for solid foods.
Solid food, sir. He was more comfortable in drinking water or some juice or something like that.
Okay, fine. Then was there an associated with pain while opening mouth?
Yes, sir.
Why was there a pain in opening the mouth?
Sir, one thing, while initially I was confused with this, sir. He said he had pain while opening the mouth, but during examination, he was able to open it completely for us to visibly see the posterior pharyngeal wall also. But he said he had pain. Initially, we thought he might be having trismus, but no.
He wasn't having any trismus. So what are the causes of trismus?
Sir, one is oral submucous fibrosis. Then you have involvement of parapharyngeal space, could be tumors or an abscess, and um, then this thing.
What sort of tumor and abscess would you think would give rise to trismus?
Sir, if it involves the this thing masticator space, because parapharyngeals, if there is parapharyngeal space abscess, anteriorly it is continuous with the masseteric space, then exposure to the temporalis tendon and all will be there. So patient will actually have difficulty in opening up the mouth also, because medial pterygoid muscle gets involved there.
Okay. What are the muscles of mastication?
Sir, you have medial pterygoid, lateral pterygoid, temporalis, and masseter muscles.
What about buccinator?
Buccinator is a muscle of facial expression, sir.
Good. Then coming back to the trismus, you're talking about parapharyngeal space and
Yes.
parapharyngeal tumors which cause trismus, right?
Hmm,
What are
sir.
the other causes of trismus you can think of?
Sir, one is this thing, trauma to the mandible itself, mandibular
Trauma to
fractures.
the mandible. say for example, you have a ramus fracture of the mandible. It will lead to trismus.
Patient will not be able to open his mouth completely, sir, because there was one.
I mean, because there will be pain, no doubt. And any classical causes of trismus? I just want to know from you how do you classify the various causes of trismus?
Sir, there can be this thing. You have
Trismus is usually classified as articular and extra-articular.
okay.
Right. What do you mean by articular? What are the articular causes? What are the extra-articular causes?
Okay. Articular causes, one is TMJ joint ankylosis, sir.
Correct. And temporomandibular joint arthritis, you can have.
Arthritis.
You can have joint infection also, septic arthritis. The joint causes per se.
Sir.
Then you can mention about fracture in the condylar area, which would give rise to trismus. There it comes as a bit of extra article. Then other extra article causes, what can you think of?
Sir, oral submucous fibrosis.
Yes,
Pretty common.
fibrosis.
And this thing, deep neck space infections involving the parapharyngeal space, masseteric space with this thing.
Anything more? Any other malignancy which would lead to trismus?
Malignancy, sir, you have
any malignancy of paranasal sinus you can think which can lead to trismus?
You have nasopharyngeal carcinoma, sir, because that will readily go into this thing, parapharyngeal space. So eventually, the patient can have trismus there.
More common than nasopharyngeal carcinoma, what you have here in India? What about malignancy of paranasal sinuses?
Okay, this thing.
Can you think of any malignancy of paranasal sinus which can lead to trismus?
Maxillary sinus carcinoma, sir.
Yes. How does maxillary sinus carcinoma lead to trismus?
Sir, there is you get extension, sir, posterior wall. Sorry.
And what happens? What does it involve, the posterior extension?
It will go into pterygomaxillary space, sir. From there on, it will go laterally and get abutted to the temporalis muscle. Get involved in that eventually.
Temporalis muscle?
Sorry, no.
It involves something more than,
pterygoid, sir. Pterygoid, sir.
Pterygoid and pterygoid muscle. There you get trismus. So you need to know the various causes of trismus because that is linked with your, presenting illness of, history that way. Correct?
Okay, sir.
Fine. So, okay, we can switch out to the other slide. Again, the voice change is not sudden. You can say it is acute. And obviously, why was it associated with pain while speaking? Do you have any idea?
Sir, because it is an inflamed area, one thing, his voice also was not proper. And whenever he tried to repeat his sentences, he complained of pain.
I mean, you've already mentioned it had some sort of hot potato voice. Obviously,
Yes.
if you have a inflammatory swelling, you will have somewhat pain also while speaking. Can you switch to the next slide? Again, there you are right. That's acute in onset, rapidly progressive, and associated with pain. That means the swelling the left upper side of neck near the jaw, that's the level 1B, was also inflammatory.
Yes, sir.
Right. So if that would have been an inflammation, where would have, what source would have it as an infective source? You get the point?
Mainly the dental infection, sir.
Okay. So did you see the dentition?
Sir, yes, sir. But it was poor. It was poor, sir. Poor oral and dental hygiene was there because he kept repeatedly chewing. But dentition was teeth were normal, sir. There was no edentulous teeth or any swelling of gums or as such.
So, did he have dental caries also?
Not that I'm aware of, sir. At that time,
There was no dental caries, there was no root canal problems, then how can he get a dental infection? If you see that, if you find that dental examination is normal, how can you say that it is because of dental pain and what the patient is having lymphadenopathy with?
sir, there could have for sir, this thing because uh, he had swelling in near the lower jaw, sir, but the swelling of gums or erythematous gums were not there. Secondly, upon doing the scan also, this thing we could not see any other neck spaces in getting involved, like submandibular space or sublingual space. But it's somewhat more posterior to the this thing. Uh, so probably surrounding inflammatory area might have been there.
Might be, you're right. Floor of mouth infection can have, especially with such a severe diabetes patient of 58 years of age, you can have some sort of local infective foci, not really the teeth as such, since the teeth examination are normal, what you have just pointed out.
Sir,
All right.
sir.
So this is what I feel. You can have a source of infection that way. Once he has difficulty in swallowing with bad oral hygiene and all, but certainly not teeth unless until you find some root cause in teeth per se, right?
Hmm.
Just switch on to the next slide. So you don't have any negative history of
Yes, sir.
these points. What is the significance of night sweats?
Sir, in case if the patient has a history of tuberculosis,
Mhm.
then patient can have because of this thing also. They maybe a patient might have had this thing if uh, patient can have TB, but patient need if there is TB, however, there can be involvement of retropharyngeal space also. But patient will present with a cold abscess. There won't be uh, any
Can you think of night sweat somewhere else also?
sir in non-Hodgkin's lymphoma, sir. Sorry, Hodgkin's lymphoma.
Hodgkin's disease. So, right. So night sweats have their relevance, especially if the tonsil is enlarged, while staging Hodgkin's lymphoma.
Okay, sir.
He was also having difficulty in breathing.
No, no,
No.
no. He did not have any difficulty in breathing, sir.
Okay, fine. He didn't have any stridor. He didn't have any sort of snoring also.
No, sir.
So, okay, fine. Switch on to the next slide, please. Uh, Fine, you can switch on to the other slide. That's okay, fine. Go ahead. What is the role of tobacco chewing and smoking with relevant with your disease?
Sir, tobacco chewing or smoking will cause a poor oral health, sir. One.
Anything more?
And besides that, if the one, it will cause a dryness in the oral cavity, sir. So any smoker, chronic smoker, will have a recurrent dryness in oral cavity, and there's a possibility that local immunity also can be reduced because of heavy smoking.
Let me tell you, tobacco smoking has been linked to peritonsillar abscess. And
Okay,
obviously, if you have a combination of tobacco smoking with uncontrolled diabetes,
sir.
that gives a significant more risk for developing the quinsy. But
Okay.
once it comes to bilateral peritonsillar abscess, what you are presenting, I think tobacco smoking has a significant relationship as far as the literature goes. So tobacco chewing and tobacco smoking particularly is
Okay.
important in the etiology of quinsy, right? So
Okay.
that is something you need to know.
Okay.
Is alcohol consumption associated with this also?
Sir,
What is I mean, what is the reason of taking personal history of alcohol consumption?
sir, for his age, we, especially in the Northeast, sir, we have seen patients who they come with a combination of betel nut chewing, tobacco chewing or tobacco smoking and alcohol consumption. And
I
they
mean,
tend to have oral cavity cancers. But I am not aware of the direct link between peritonsillar abscess and alcohol consumption.
no, alcohol doesn't have any link as far as the literature goes, but yes, non-vegetarian diet has. What is the role of non-vegetarian diet in quinsy?
Sir, a patient consuming fish or chicken, sir, especially the fish bones can get lodged into the tonsillar area, sir. So, patient with uncontrolled diabetes.
Okay, suppose he's taking a boneless meat, then
Uh,
the point is the non-vegetarian diet is more inflammatory than a vegetarian diet. And the person who is more exposed to getting tonsillitis usually has enlarged crepes. So if
okay.
non-vegetarian diet gets entrapped in those crepes, that is more likely to produce an inflammation rather than a vegetarian diet per se.
Okay.
So this has been reported that a non-vegetarian diet predisposes to recurrent tonsillitis, especially where the crepes are enlarged. So
Enlarged.
that might be linked with your uh, peritonsillar abscesses per se as compared to vegetarian diet. But that is a sort of an anecdotal statement. It has been quoted by very many authors, but has not been, established, but yet it's speculated. Rather, otherwise, appetite and adequate sleep that really don't matter in this peritonsillitis presentation, per se, right? So, switch on to the next slide, please. Okay, no history of family. I mean, there might have been some family history of diabetes. Have you?
Yes, sir. I have asked him, sir. He said no.
There is no history of diabetes anywhere in the family, such a highly uncontrolled diabetes. Okay, go
No,
ahead.
sir.
Okay, you took consent and everything, and there was no generalized nephropathy also. Pulse was 86. Okay, go ahead. Uh, the temperature was normal at the time of examination. SpO2 was 97%, RBS was 420, pretty high. Go ahead. Okay, next. Coming on to the PMT examination. Bilateral anterior tonsil pillars congested, left tonsil enlargement grade 3, right is grade 2. Soft palate. Okay, fine. Uh, you tell me the classical signs of chronic tonsillitis. Say, for example, if the patient has a chronic tonsillitis, then what classical findings would you find when you do a oropharyngeal examination?
Sir, there'll be enlargement of tonsils. Then the you will find uh, there can be expression of pus also on
Very good.
pressing the anterior
Very good. Number
tonsil
one.
pillars,
Number two.
and there can be there can be the posterior pharyngeal wall also, sir, that can appear inflamed, and there can be we can have some in you can also find tonsillolith also in the near the upper pole.
Mhm. I'm afraid there are three important findings you need to know about chronic tonsillitis because this chronic tonsillitis might have predisposed to having bilateral peritonsillar abscess in this patient. So you need to know the classical signs of peritonsillar abscess. Oh, sorry, chronic tonsillitis. So one, you have rightly mentioned, when you press the tonsil, you can have exudation of the sort of the secretions which might have pent up in crypt. They may come out. Cheesy debris you can find that way. The most common finding in chronic tonsillitis is flushed anterior pillars.
Okay.
Right? So flushed anterior pillars you haven't mentioned. That is one thing you need to be very clear about. Third point for chronic tonsillitis is that you might be having some sort of level 2 lymph node. As you have said, you have sub-centimeter lymph node on the left side. You might be having some just palpable lymph nodes, but they won't be painful at all. They won't be tender. So out of these three signs, that is non-tender jugular-digastric lymph nodes, or the tonsillar group of lymph nodes, what we call it as. Secondly, exudation of secretions when you press the tonsil. And thirdly, the flushed anterior pillars. If any of the three are present, then you call it a chronic tonsillitis. And if the chronic tonsillitis is there, that predisposes to quinsy, especially in immunocompromised patients, and especially the severe diabetic, what you just mentioned, right? So,
Sir.
signs of chronic tonsillitis you need to know. As you have rightly mentioned, there was congestion of the bilateral anterior tonsil pillars. Obviously, tonsil enlargement. Was it a tonsil enlargement, or was it just like the tonsil being pushed by the peritonsil abscess underneath it? That is something you need to clear after you drain out the abscess. Uvula was swollen and congested with mild deviation on the right side just because of the pressure on from the opposite side.
Sir.
And then all every aspect you found was absolutely normal, except for the mouth opening was restricted and painful. Kindly explain this. Why was it restricted and why was it painful? If you say there was no trismus, then why was the mouth opening restricted?
Sir, though sir, actually, when he was trying to open his mouth, he had pain. So that appeared to us like a trismus first. That is one thing that I got confused. But eventually he was able to open his mouth and we were able to visualize, sir. So there was no trismus as such.
Okay. So if there was no trismus, then why was the mouth opening restricted?
Uh,
Why was it restricted?
we had to persuade him again and again. He kept saying that I have pain while opening the mouth. So eventually he was able to open the mouth, but slowly he kept opening his mouth. So
okay. You can switch on to the next slide. So you saw some mandible swelling. Okay, I agree with that.
Good evening, Dr. Anupam and Dr.
Hello, Dr. Nilma. How are you?
Yeah, I'm fine. Actually, initially I could not unmute myself, so I logged in from another device. So I just wanted to ask one thing. Any comments on the right-sided soft palate? Like you said, left-sided there was a tender swelling,
yes,
but right side palate was normal.
yes,
Soft palate.
yes, initially yes, but once we did the incision and drainage of the left-sided peritonsillar abscess, 2 days 2 days later, he started developing pain on the right side. A day after that, when we examined him again, there was bulge on the right side of the soft palate. But initially, at the time of getting admission,
Initial examination, it was
it
okay.
was not there.
Okay. And when would you say that the mouth opening is restricted?
Ma'am, if he actually has trismus, when there is involvement of, say, parapharyngeal space with the
No, on examination, when would you say that this mouth opening is restricted and this much mouth opening is normal? Is there any criteria?
Ma'am,
And how would you classify it? If the mouth opening is restricted, how will you describe it so that the other person can get an idea how much it is restricted?
Ma'am, so manually we can put our fingers and check. So if it is less than 3 fingers or something like that, then it is restricted. But the finger size for each individual is different. So we can think of the distance between the incisors.
So you can describe that how much is the mouth opening? 2-finger distance or 3-finger distance or 1 finger. So that the examiner can also get an idea that this much is the restriction, or the mouth opening is only 1 finger breadth.
Okay.
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 I mean, but what you had said, you didn't have any trismus.
Yeah.
No.
How many fingers could you insert at a go?
So 3 fingers.
3 fingers.
Yes.
Okay, go ahead. And Dr. Neelima, all yours.
And yeah. Go ahead.
Mr. Sir, can I just ask a question, sir?
Yeah.
Yes, sir. Thank you, sir. Sir, the speaker, he was mentioning about peritonsillitis a few minutes back, sir. I want to ask him, how can you differentiate between peritonsillitis and peritonsillar abscess? Are they both synonymous, or, of course, they are not same? Is there any way to clinically distinguish them, or you need radiological investigation?
Sir, clinically, the peritonsillar abscess, there'll be bulge at the dependent position, sir. That is one thing, which may not be present in case of peritonsillitis. Second, deviation of uvula is very marked in case of peritonsillar abscess, not in case of peritonsillitis.
Okay. Do you feel that many cases of peritonsillar abscess may be wrongly diagnosed as peritonsillitis? So this might be the reason why there's such a low cases of peritonsillar abscess being reported.
It is possible, sir. It is possible
Because we have to remember that tonsillitis is, of course, a bilateral disease. In most cases of tonsillitis, we have tonsillitis in both the sides, right side, left side. So if peritonsillar abscess can occur in one side, there's every chance that it can also occur in the other side. So do you feel that the cases of peritonsillar abscess are wrongly diagnosed as peritonsillitis? That explains the very low cases of peritonsillar abscess.
Sir, there are two explanations for this. One, because with increasing awareness about oral hygiene and all, and use of better antibiotics in today's era, maybe the tonsillar infections also are less. Secondly, there is a possibility that peritonsillitis and peritonsillar abscess, there might be a misdiagnosis in that.
Speaking of, now you have mentioned about the use of antibiotics.
Sir.
So we see that in many patients, antibiotics work and we don't have to go for incision and drainage. So at what point should you go for incision and drainage? Is there any, are there any criteria that beyond this point you should go for incision and drainage? Because we have seen 1 or 2 patients, they respond equally well to antibiotics without having to go for surgical intervention. Do you feel that these are the criteria? Beyond this point, we can't continue with antibiotics, we have to go for surgical intervention?
Sir, if it's a small sized abscess, say less than 1 centimeter or something, if that is found, or less than 2 centimeters. So if we can manage it conservatively, we can wait and watch for 24 to 48 hours. Otherwise, it is better to drain an abscess once we get to know through radiological investigations.
And then speaking of surgical intervention, we have seen that in many cases, instead of incision and drainage, we go for aspiration, needle aspiration. So,
Yes,
so what do you feel about needle aspiration and vis-a-vis incision and drainage? Do you feel that needle aspiration may be enough instead of going for a more radical IND? Because IND, of course, is more radical. It might cause more trauma, more bleeding. So instead of that, do you feel that incision and drainage, instead of doing incision and drainage, we can go for simple aspiration needle?
Sir, needle aspiration, it would be actually useful in collecting the pus in a sterile way. But if we do incision and drainage, we'll be getting rid of the abscess once and for all. We'll be assured that we can drain it. So we don't want.
I think Dr. Datta Saab has made a very important point. Would
Yes,
you
sir.
like to go for needle aspiration every time you think for incision or drainage, or you would straight away like to go for incision drainage to start with?
Yes, sir.
Sir, we can aspirate it first, sir. So that
Can or you will?
we have to, sir. We have to aspirate
You have
first.
to, you will. If, say, for example, can you think of any other condition which would create havoc if we just do incision drainage without aspirating?
Exactly, sir. Exactly, sir.
Sir, extracranial ICA aneurysm, sir.
Yes, it can be infected aneurysm. Then what will you do while, if you want to just do incision drainage, then what would you like to do first?
Sir, clinically, sir, we'll be able to feel this pulsatile swelling, sir.
Yeah, you need to palpate it first and then you put a nick, not before that.
Yes.
Dr. Datta sahab, aap boliye, please. Thank you.
Yes, sir. Thank you, sir. Sir, that is the only question. And then, sir, I had another question. Uh, uh, I mean, peritonsillar abscess, we know it is a microbial condition. So, though Streptococcus pyogenes is the most common organism involved, but we find other bacteria also. So, before the culture report comes, what antibiotic do you prefer?
Sir,
Because a culture report takes 2 days, and are you going to start an antibiotic before 2 days? And if you start an antibiotic, what antibiotic do you prefer?
sir, I would prefer, say, amoxiclav or second generation cephalosporin, along with metronidazole, sir. IV antibiotics, all of them.
Have you found any study where these antibiotics have been proved to be more effective than other antibiotics? What about linezolid?
Sir, linezolid, sir, if the patient is resistant to these cephalosporins, and especially we have also seen some diabetic patients, linezolid tends to work better in them.
Mishra sir, do you want to comment on this? Do you have any insight?
Say that again. I was just on the phone actually. My wife had
Yes, sir.
called me.
Sir, I was asking the speaker that before we get the culture report, do we start any antibiotic prophylactically? And if we start, what antibiotics are preferable?
Yes. What did you answer?
Sir, I told, sir, we can use IV antibiotics, amoxiclav or second generation cephalosporins, second or third generation, along with metronidazole, sir.
Okay, you'd like to have gram negative, gram positive, and anaerobic coverage.
Anaerobic cover, sir.
So, it all depends. These days, we are more dependent on hospital supply than actual antibiotics. But point is, you had Klebsiella, if I'm not wrong,
Yes, sir.
and you started with ciprofloxacin.
Yes.
Okay, ciprofloxacin. In case of Klebsiella, I think ciprofloxacin metronidazole would be a nice combination to start with, provided if you do a meticulous blood sugar control.
Yes.
That is the first rate, because without that, there's no fun doing anything.
Correct, sir.
Hello, am I audible?
Yes.
Yes, sir.
Okay, fine. So go ahead, please. अच्छा अभी बात कर रहा था first time. Right. So this is what, and next slide. Next. Next. Okay, fine. So you have made a diagnosis of left-sided peritonsillar abscess.
Yes, sir.
But you had a right side also.
Yes, sir.
So why do you not mention the right side out here?
Sir,
only the left side.
Sir, he had pain on the left side of neck also.
Okay,
So
fine.
we thought it could be left-sided peritonsillar abscess, and probably there might be peritonsillitis on the right side. But upon doing the contrast enhanced MRI, it got confirmed.
Okay, fine. So just clinically, you made a diagnosis of the peritonsillitis on the left side.
Yes, sir.
Okay. I think we have already talked about various malignancies. You can have leukemias and lymphomas presenting also in the same way. What about, let me ask you, what are the causes of membrane over tonsil?
Sir, it could be a bacterial infection, could be candidiasis, could be infectious mononucleosis, could be malignancy. Then there could be diphtheria. That is one of the main causes. And
Have you heard the name of orange tonsils? Orange tonsils.
orange tongue? No, sir. I'm not aware.
Not aware. Okay, fine. I'm just curious to know that that's a lipid disorder where you have orange colored tonsil. It has got nothing to do with infection per se. That's a lipid disorder known as Tanger's disease, right? So, fine. Can we switch to the next slide?
Sir.
Fine. So the total leukocyte count was around nearing 12,000.
Sir.
Okay, go ahead. Go ahead again. You saw this MRI after you drained the abscess or before you drained the abscess?
This is before draining the abscess, sir.
Before draining the abscess. You can
Yes.
see sort of a bigger abscess on the right side and the,
left side, sir. This is
yeah, on the left side and lesser on the right side.
yes, sir. This.
I think Dr. Datta already asked you about when would you like to go for conservative management, but you have to drain it. Okay.
Yes.
You can switch on the next slide. Okay, fine. So, okay. What are the sequelae of an abscess, an intratonsillar abscess presenting as a parapharyngeal abscess? How does it progress?
Okay, sir. The intratonsillar abscess.
How does an intratonsillar abscess start?
Sir, there is local infection in the crypt, sir. First, because a food particle might have been trapped in the crypta magna.
After that?
After that, there's formation of intratonsillar abscess. That intratonsillar abscess has to rupture. That will leave the entire infective or inflammatory material out of the crypt. That will form a cover around the tonsil. So leading to peritonsillitis.
Okay.
And after that, there's a stage called phlegmon. It's just before the abscess, but without a wall. It has no wall, basically.
Right.
And once a wall is formed, a peritonsillar abscess is formed.
Okay.
Now, if there is burst of that abscess also through the lymphatics, this will eventually travel into parapharyngeal space,
Okay.
ultimately forming an abscess there.
Okay. In this case, if you have a bilateral peritonsillar abscess, do you think that it started as a unilateral abscess and then spread into bilateral, or it started simultaneously as a bilateral abscess?
Sir, it could have started first on the left, and then there could have been peritonsillitis and other sequelae on the right later.
On the right side.
That is why maybe the patient had bigger abscess on the left compared to right.
Oh, you might be right up to a certain extent. Can you show the next one?
Sir.
Yes. You did cefuroxy. Okay, fine. Then you started with insulin. I don't want to ask you the management about blood sugar, but since you discharged the patient, was the patient on any anti-diabetic medication or not? Because you didn't show that.
Okay, sir, at the time of discharge, he was given metformin, sir, about 1 gram, and along with that, he was given this. I'm not able to recall what's that. There was another drug that was given, sir, but
So you didn't mention that.
okay.
Okay, fine. So,
Dr.
okay.
Abhishek, how did you do the incision and drainage?
Ma'am, we made the patient. Patient was in sitting position. Then, with adequate vision, ma'am, we looked at the most dependent position. Say theoretically, it's a horizontal line extending from the base of the palate, base of this thing uvula, and also the vertical line coming along the border of anterior tonsillar pillar. So the point where that two lines bisect, theoretically that is that, but somewhere around that area, out on the outer side of it, that was a dependent position, and we
dependent position.
That is a point of maximum bulge, ma'am. That's what I meant to say.
Yeah, what would you mean by a dependent position in a patient sitting with a peritonsillar abscess? So maximum bulge
Point of maximum bulge.
at the point of intersection. Okay, and what else? Any precautions you would take?
Ma'am, we did this in a minor OT, ma'am, so that if in case there is uncontrolled bleeding or anything, we have immediate access to OT. And
anything else?
Before doing this entire
To
procedure,
prevent the complications.
second, we should have a suction in handy, ma'am. Because because if there is any pus coming out, we have collected, we have aspirated, okay. But for the additional pus that will keep coming out, we need to suck it properly so that patient doesn't swallow it or even aspirate.
What instrument did you use for the incision and drainage?
Ma'am, we used a 11 number blade. Otherwise, Quincy forceps
any precaution while using this 11 number blade?
Ma'am, the depth of penetration of the blade, we need to be, it's like a stab. We need to give a stab and...
So it has to be a guarded incision and drainage. And we used to, in fact, put a leucoplast or something sterile to cover the, we just use maybe the initial 8 millimeters or that much of the blade, and rest we would cover, so that if the patient gags or somehow if he comes anteriorly, so it has to be a guarded penetration of the stab, so that you don't accidentally injure the surrounding structures, or you may not go deep enough to go into the posterior pharyngeal wall, because the mouth opening is restricted and painful, and you may not get a very good vision also. So it has to be a guarded incision. Okay, and after that, you would like to dilate this opening using an artery forceps.
Yes, ma'am.
So that the pus can drain properly. And you can give a kidney tray to the patient so that he can bring out the pus.
No.
Okay. Go ahead. So you want to ask anything else?
I think you just done a wonderful job. I just want to know, is there any role of Quincy forceps? Have you seen Quincy forceps?
I have seen, sir. Only in MBBS time I've seen.
How does it look like?
Sir, it has got, it's just like it has got two pointed ends, sir. It's like an arrow.
Yeah.
And it has got this thing, what do you call it? It's more like a curved forceps where we can do.
Curved forceps? No, it's not like curved forceps. So, I mean, do you need a knife before you use that Quincy forceps?
Yes.
No. But you have seen something else.
Is it like a myrigotomy knife?
Yes,
but different.
But we can actually use that to make it.
She has given you a hint actually. But you need to think twice before replying.
Okay.
I mean, you're free to answer whatever you want. I'm not interfering you at all. But just trying to give you a hint of it. Have you seen Quincy forceps?
It's been quite a long time, so to be honest.
Okay,
otherwise,
fine.
Beyond books, I have not. Okay, but only in MBBS I saw it once.
As Dr. Nilma said, it's sort of a triangular apex where you insert it in the abscess and along with suction, and you can dilate it both the ways, the vertical plane as well as in the horizontal at right angle to the first one, so that the opening enlarges and then suction of the pus. This bilateral tonsil abscess, I haven't seen since I joined as a faculty, but what I have read once upon a time that there is a lot more chances of respiratory obstruction in this case. But you didn't have any breathing problem here in this patient?
No, sir.
Right? Okay, fine. So my next set of questions would be like, what would you like to advise the patient after discharging the patient?
Sir, first thing is I would ask him to maintain his glycemic control. That is first and most important thing.
Okay.
Second thing is oral dental hygiene, sir. He has to focus on that.
Okay.
So, chewing of betel nut, or even if he starts chewing tobacco also, all that should be stopped.
Okay.
And then comes the if he can go for regular dental checkups because he's a diabetic patient and any possibility of dental infection, if he can avoid that, then he can take care of it. Then
when would you like to patient, call the patient to follow?
Sir, after 2 weeks, sir. With this patient, we called him after 2 weeks.
Okay, then if you see everything fine then.
Yes, sir.
Would you like to go for tonsillectomy in this case, or would you like to?
First thing, sir, again, if there is recurrence,
I think
or there was the history of similar complaints in the past also, we would advise him for tonsillectomy, sir. See that, but the duration should be at least 6 weeks post discharge.
Dr. Datta, you were trying to ask something.
Yes, sir. Sir, I just wanted to make one point, sir. Because, sir, in certain literature, we have found that they advise tonsillectomy during the acute attack of quinsy, sir. When quinsy is occurring at the same time, they do the tonsillectomy. Yes, sir. Sir, not sir interval tonsillectomy, but I've seen people doing tonsillectomy during the attack of quinsy. So when do it? What are the conditions where you can do tonsillectomy instead of asking the patient to come after 6 weeks? Can you do tonsillectomy at the same sitting while the patient is having this quinsy attack? Are there any criteria?
Sir, that would be a very risky affair, sir, because once we do tonsillectomy in a highly inflamed area, there's going to be recurrent bleeding. So keeping that in mind, we would better drain the abscess first, treat the entire thing, bring his glycemic bring his blood sugar under control, and then it's better to go for tonsillectomy after 6 weeks.
Sir, I'm asking Mishra sir as well as Nilima Gupta ma'am, sir, whether this can be done, because I've seen in certain literature where they in immunocompromised patients they do the tonsillectomy immediately, sir, so that there is no further complication, further sequelae.
Sir, as far as I am concerned, I will not do the tonsillectomy unless we have a strict control of blood sugar in this case.
Yes, sir.
He has a HP1 A1C of around 15 and 420 milligram per deciliter blood sugar.
Yes,
So
sir.
actually, he has a strict glycemic control. I would
Yes,
not
sir.
like to do, tonsillectomy in this case per se.
Yes,
But
sir.
if we have everything in our hand, then obviously, theoretically, you can go ahead.
Yes, sir. Yes, sir. Because sir, precisely, sir, this is the reason why I'm asking this question, sir. Because in certain series, we have found that they have gone for tonsillectomy during the acute attack of quinsy, sir.
It's reported by very many authors, no doubt about that.
Yes, sir. Yes, sir. Exactly, sir. Sir, I've seen it, sir.
I agree with you. And Dr. Nilima, would you like to comment on this? I think she is muted herself, if I'm not wrong.
Yes, sir.
Okay, fine.
Sir, one more point, sir. Sir, there's a message in the chat, sir.
Yeah.
Meraz Kazi, sir, he has mentioned about Irwin Moore's sign, sir. Irwin Moore's sign. Irwin Moore's sign.
He just, I think, narrated. When you press the anterior tonsil pillar, then you have exudation of the debris out of the tonsil crypt. That we call it Moore's sign. He didn't mention it by name, but he had mentioned it by.
Yes, sir. Yes. So we call it the Irwin Moore sign, sir. Yes, sir. Yes, sir.
Yeah.
Yes, sir. Yes, sir.
I think we are over time, if I'm not wrong.
Yes, sir. It is 7:27. We are over time by 20 minutes, sir. Sir, do you have any other, sir, question, sir?
If you want to ask something, Dr. Abhishek, you're most welcome to ask any one of us.
Yeah.
Sir, yes. In Scott Brown, sir, he has given that try to manage the abscess wherever it is possible, conservatively. So what is your take on that, sir? Because old timer surgeons, they say that if you find an abscess, please drain it. That's the first thing that they keep telling. So to what extent are we supposed to follow the old rule, or what is the criteria for the conservative management in deep neck space infection like this?
Okay, as far as my training of surgery is concerned, my teacher straight away told me, till it is the stage of cellulitis, you just need to give antibiotics and nothing else. Once it is an abscess, that too when it is not likely to drain by its own self, then you have no option but to aspirate the pus if it is very small, or to drain it off completely. Because once you have abscess in a closed cavity, then you need to get rid of the pus, provided the pus is not minimal enough to be absorbed or drained. So it depends upon the situation. With this sort of abscess, what you have, I think the aspiration might have been the first thing you would have tried, and obviously, if the aspiration has failed once, then go straight away if it's in failure. I mean, this is what my feeling goes if the case had been in my hands that way at my institute. But otherwise, you just cannot leave abscess in a closed cavity waiting for it to absorb all by itself, unless and it is very small. And in fact, you think that there's some sort of self-drainage associated with that. Yeah, and Dr. Datta,
Yes, sir. Sir.
anything you would like to add to Dr. Abhishek has asked?
No, sir. I think, sir, we have covered most of the topics, sir. Most of the important points.
Okay.
Yes, sir. Sir, is there any other questions, sir? I've seen the chat box, sir. I think that is the only thing that was, sir, worth discussing, sir.
Okay.
Yes, sir.
Good.
Yes, sir.
And Dr. Neelama, would you like to say something more? Dr. Neelama?
No, I think I appreciate Dr. Abhishek. I think he covered most of the points.
Yeah. I think he's done a good job, except for few things what you can always improve. I mean, this is your second year, and by the time you're through, by the end of the third year, you might be knowing all these things.
Sir.
I just wish you all the best.
Thank you, sir.